I'm Chandler, and today I'm going to be talking about adaptive support ventilation, otherwise may known as ASV. I'm currently from Georgia. I'm a registered respiratory therapist here, where I've spent most of my career for 5 years. And I just want to start off with a little quote that I found. It says, "To know even one life has breathed easier because you have lived, that is to have succeeded." And to me, whenever I read that, I just automatically thought back to whenever I was a student, and one therapist might have done something a different way versus how another therapist would. But in the end, our result is to help that patient breathe easier, decrease that work of breathing. We may give that breathing treatment a different way. We may decide to tweak vent settings a different way versus another therapist. But in the end, our goal is to always help the patient breathe better. And, we're all doing the best I can. So I just ask, during this presentation, if you've used ASV in a different way versus I have, I would love to hear, how you have used ASV and what situations you have used ASV in, and what indications you have thought to use ASV. So, so let's get started. So, learning objectives today that we're going to be going over is to define ASV and review some of its history. We're going to be understanding how ASV works, as well as conditions that may benefit from ASV, indications, contraindications, how to apply ASV, when to apply ASV, and as far as when to wean on ASV. And then we'll just have a summary and some of my resources I've used to complete this PowerPoint. All right, let's get started. So, the development of adaptive support ventilation. So, ASV was just an idea in 1977 from Dr. Hewlett. Later on in the 1990s, someone named Dr. Floor actually made this ASV available on vents, and he sold it. Whenever he sold it, he was mostly using it on the Hamilton medical vents, which I know a bunch of us still use to this day, and then also on the Galileo vents and G5 models that some of you may be familiar with. Personally, I see it on the Hamilton models. ASV automatically adjusts a patient's respiratory rate, tidal volume based on their lung mechanics and breathing efforts. This mode sometimes is called no mode or integrated mode just because it's highly adaptive on reading the patient's characteristics and can set settings itself that we're used to setting. So here's my introduction for ASV. ASV is a closed-loop ventilation mode that selects and continuously adapts to the respiratory rate, the tidal volume, the IE ratio, and that's depending on the lung mechanics of the patient. So that's, what we learned in school, the compliance and resistance of those lungs, those alveoli, and the effort from intubation to extubation in a 24-hour period. So what that basically means from intubation to extubation time, that the ventilator in ASV is constantly recalibrating that respiratory rate, the compliance, the resistance, and going to adjust those settings on itself. So we're not having to do that. That helps with the decrease of ABGs. So just think, if you notice that the patient's lungs are getting stiffer, their pH may be getting worse, CO2 is getting worse, the vent is going to notice that before we do in most cases and going to adjust those settings. So when it's adjusting those settings to the patient, it may be correcting those ABGs on its own. And I don't know about your hospital, but I know at mine, we are ABG happy. And if you ask anybody, they hate ABGs. They hate being stuck by ABGs. They're not comfortable, but it's something we have to do. But it's just a really great feature ASV has in just adjusting those settings that we're not having to do all the time. If you go change something on the vent, get a gas 30 minutes, 45 minutes later, and then recheck it. The gas is not great. Okay, let's go in and change those settings and do. But instead of doing all of that titrating and changing, the vent is calibrating on those patients' compliance and resistance and doing those changes for you. So whenever you go in to set an ASV, you roll the ventilator in, just intubated a patient, you're putting in your settings, it's still the same. You're going to set their ideal body weight, their gender, their PEEP, their FiO2. This time you will be setting the target minute ventilation, and you will also be setting the max pressure alarm, which is still the same. Depending on the patient's breathing efforts, ASV can switch between delivering and control breaths when the patient is not breathing actively versus pressure support when the patient is attempting to breathe on their own. The ventilator uses flow sensors. I know we all know what a flow sensor is because they're either hard to find, we're always changing them, having to be cleaned. But the flow sensor helps to measure the patient's respiratory effort and bases the pressure support delivered off of those efforts. So it's really nice that the ventilator can change the pressure support looking at the compliance and resistance of those lungs. So this helps to prevent tachypnea, development of auto-PEEP, and excessive dead space in a patient. And the goal of ASV mode is to always ensure adequate alveolar ventilation and decrease work of breathing. I think as respiratory therapists, our goal at the end of the day is to always make sure our patient is breathing easier. They're not working to breathe on the vent. They're not, trying to breathe over too much on the vent, trying to keep up with the vent, and just to always make sure that they're oxygenating on the ventilator. So, the vent is really good. The setting's really good at noticing when a patient is starting to trigger a breath. This may help to, hey, they're triggering more on their own. Let's start SBTs a little bit sooner, So let's go to the next slide. How does ASV work? In ASV, the inspiratory pressure and the respiratory rate are automatically adjusted by a micropressor to help minimize the work of breathing. So like I said earlier, the ASV is always going to be changing those settings. Inspiratory pressure, respiratory rate, trying to adjust for what is comfortable with the patient to decrease that work of breathing. The micropressor switches from controlled ventilation, CV, to assisted ventilation. So unlike standard ventilation modes, ASV doesn't rely on fixed settings. Like stated before, it modifies those settings, titrates them themselves, bases on tidal volume, inspiratory pressure, depending on the patient's lung mechanics. That can also be airflow, pressure, lung compliance to match the patient's needs. It is a breath-by-breath ventilator in recalibrating and checking settings. So, like I said, from intubation to extubation around the clock, 24 hours, it's constantly checking those settings. One thing I read on while researching this is some doctors say that's great because we don't have to be in the room all the time. Well, it is important to be in that room as much as possible, but we also most of us have other patients, the ER, other floors call, deliveries. So you cannot be in the room 24/7 like we wish we could be. Right now in this sick time, I know we wish we could be, but everybody's sick. So it's really nice in the fact that this ventilator is going to check that for us. We may not be there the first time that patient starts breathing over the vent because their sedation is getting weaned down, and the nurse forgot to tell us 20-30 minutes ago that, hey, I forgot to tell you I turned the sedation down, and you walk back in and the patient is trying to breathe over that vent and alarming and coughing and trying to wake up, open their eyes. So the vent is nice in the fact it's going to keep up with that and help keep that work of breathing down for them as soon as they open their eyes and they're freaking out. They got a tube in their mouth, down their throat. So it's just going to help keep them relaxed a little bit. ASV helps to practice lung protective strategies to minimize complications from auto-PEEP and barotrauma by using flow cycle breaths where the ventilator delivers a set pressure support until the patient inspiratory flow decreases to a certain level, indicating the end of inspiration. So all that's saying is that this is like a safety feature in the ventilator. So it's just going to help keep the auto-PEEP down, help keep barotrauma down when the patient's trying to breathe on their own. And like I always said, that goal of adaptive support ventilation mode is to ensure adequate alveolar ventilation and minimize work of breathing. And at the end, it says transitioning the patient to optimal breathing pattern, which is just like us, off the vent, breathing normal. That's our goal, is to get the patient back to the normal, being able to breathe on their own, being able to sustain that on their own after the ventilator is removed. We don't want to ever remove the vent, intubation, and have to re-intubate them. That's always our goal. I know it doesn't always happen that way, but that is our goal. So who benefits from ASV? ASV is used in critically ill patients. It can be used, in a respiratory distress that just rolled into your ER, or somebody that went to a respiratory distress that was located on the floor. You may notice it in ARDS patients, neuromuscular weakness patients, and COPD patients. As far as ARDS patients, it's always important to watch that compliance and resistance of the lungs, how much pressure is being used, and you got that max pressure alarm to make sure you're not going to go over a certain amount of pressure in those lungs and can cause barotrauma, autopeep, anything like that. So ASV is a really great feature to use in a patient with ARDS. As far as neuromuscular weakness, it's great because in ASV, those patients can still trigger a breath on their own. And when you're trying to wean, I think it's really great in neuromuscular weakness, because if you see them trying to trigger a breath on their own and you feel like they're going to be able to do good, you may start doing those SBTs a little sooner, because you're noticing on ASV, like, hey, they're triggering most of their breaths. They're doing really great on their tidal volumes. If they start to decrease in ASV and they start to do bad and not be able to withstand those exhale tidal volumes, then the vent's going to pick up and help with that. And as far as COPD, same thing, compliance, resistance, it's going to help with those pressures. So some contraindications in ASV may be obese patients or CSA patients, post-major cardiothoracic surgery patients, and in ASV, you really may not want to use it with patients with respiratory failure and hypercapnia issues, because you're unable to set the tidal volume and respiratory rate. So it's just, you may want to avoid those settings. And also, one thing, it's kind of its downfall with ASV is it's mostly used in Hamilton ventilators, and I know most hospitals don't really have Hamilton vents. Some indications would be, it's like I said earlier, early recognition for SBTs you may want to start performing. That means if they're passing their SBT sooner, they're getting extubated sooner. They're getting extubated sooner, they're getting out of the ICU sooner. They're getting out of the ICU sooner, less expense on them, less expense on the hospital. So it's just great in that aspect. Also, just faster weaning times. COPD and may have a harder time to wean. So just great at realizing those factors of, if the patient's lungs are doing great and they're breathing on their own, triggering on their own, they're sustaining those exhale tidal volumes. Hey, let's get them off the vent. Let's start SBT sooner. So it's just great overall if they are a great candidate for ASV. So let's talk about applying ASV and when to wean. So ASV can be used anytime during the mechanical ventilation period, from intubation to extubation. So initiation of the vent, it can be in ASV. You can start them out in ASV. If you don't feel comfortable in that aspect, you can always switch them over to ASV. So during the maintenance time, you can go ahead and switch them over. And also, at the end, when you're weaning, you can switch them over to ASV. And if they're doing great in the weaning time, they're going to pull those exhale tidal volumes. They're going to be able to sustain. And if they don't, then the vent is going to kick in anyways. So it's going to help support them. And it's also going to help keep those pressures low. It's not going to cause any issues with their lungs. It's going to be looking at compliance. It's going to be looking at resistance. And if they don't do great and you don't feel comfortable with ASV, you can always switch them over. But it is a protective mode that is continuously monitoring those lungs when we can't be there. So, weaning in ASV can be initiated when you notice the patient triggering. And if not at all, majority of their own breaths, reasonable tidal volumes considering height and weight. So that means if you look at their, ideal body weight and you feel like their tidal volumes aren't where they should be given their ideal body weight, it's going to help get them to those tidal volumes they need. And it helps just SpO2 maintaining, and always continue and monitor patients after extubation. We do that anyways. As soon as we're getting ready to wean or do SVT, we always monitor SpO2 and always monitor after extubation. Check that cuff leak, all the normals. So we made it to the conclusion of my PowerPoint for ASV. So just some key points to remember is ASV is a closed loop mode. It's continuously adapting the respiratory rate, tidal volumes, and eye time depending on patient's lung compliance, resistance, and efforts. ASV is primarily available in Hamilton vents. Therapists are in charge of setting the ideal body weight, gender, PEEP, FiO2, and that max pressure alarm, but we're also going to be setting that target minute ventilation. So ASV, of course, is great at finding out early on if patients are ready to start weaning off the vent. So that's going to help getting them out of the ICU, decrease that time frame so they won't maybe get a VAP, or decrease the time that they may get an infection, and get them out of the ICU to help with their wallet, and to get a new patient that may need to be in the ICU if you've got limited bed space. ASV is great at finding out the best breathing pattern that decreases the effort of work of breathing. We just always want the patient to be comfortable with the settings that they're on, and this is always going to help decrease that work of breathing and keep them comfortable. So with ASV, for oxygenation, wean O2 and PEEP, and for CO2 elimination, wean the minute ventilation, the minute volume, and support above PEEP. So these are just little facts just to remember if you ever feel like you want to try ASV out later on. And if you ever would love to find out more information on ASV, I have some of the links right here that you are more than welcome to click on and go through. And it's just really interesting reading about ASV and what other therapists may think about ASV. Personally, in my experience, I have never used ASV, but I did mention this to my boss and thought, wow, this is really interesting. Like, what are your thoughts on ASV? And this is what I found. And you never know, a therapist may have used this a lot at a different hospital versus another hospital that has never used it. So it's just great always hearing what other therapists think. If you ever have any information like you've used ASV, personally, I would love to hear it and hear your feedback. And just thank you guys for taking the time to listen to my PowerPoint.